Hello, everyone. I welcome you to this discussion about shoulder arthroplasty. I'm Dr. Prashant Meshram. I'm a research fellow in Johns Hopkins University in shoulder division. The topic for today is shoulder arthroplasty and how to manage glenoid bone loss. As you can know that shoulder arthroplasty is being done very commonly these days. The numbers are increasing with each passing year. And one of the main reasons why we do shoulder arthroplasty is to treat patients with osteoarthritis of shoulder. And the critical problem with that is patients who have glenoid bone loss. So the fixation of the glenoid implant is problematic in these patients. So let me pull up my presentation slide so that we can start with this particular session. All right. So we'll be talking about glenoid bone loss in shoulder arthroplasty. I do not have any conflict of interest for this particular talk. I'll be talking in three main headings. First is which kind of diseases in the of shoulder present with glenoid bone loss. How to assess this glenoid bone loss using CT scans, X-rays, and imaging methods before the surgery, and what are the different surgical options which are available to us to address glenoid bone loss. Talking about etiology, there are various different kind of diseases of shoulder present with glenoid bone loss. There's end-stage primary osteoarthritis, there is cuff arthropathy, revision cases, inflammatory arthritis, dislocation arthropathy, and dysplasias. We looked at the number of cases which are in our Hopkins database, which are operated by one surgeon between 2009 to 2017. We found that 90% of the cases which presented with glenoid bone loss were either had the etiology of primary osteoarthritis, cuff arthropathy, or revision. So looking at the pattern of the glenoid bone loss which presents in primary osteoarthritis, as you know that osteoarthritis is age-related wear, so there is reduction in the joint space. There's also osteophytes, which you can see here. But the pattern typically, if you see in the axial planes of the CT scan, we can know that these patients present either with a central glenoid bone loss or with a posterior wear, which typically is a posterior subluxation. Differently in cuff arthropathy, these patients present mainly with a superior wear with reduction in the acromial-humeral distance. There is glenoid erosion, astabilization of the acromion, as you can see here. So now that we know which different kind of diseases presented, what is critical to know is how to assess this glenoid bone loss before surgery. This is very important for shoulder surgeries because to do preoperative planning is because when we open up these patients and we have a very limited vision, even with the best of the retractors and the best of the assistants, we see a very limited amount of glenoid. We do not know the relation of the glenoid bone loss with respect to the scapular plane. In order to reproduce the desired results which we want, we need to plan these patients beforehand, and we need to know how much glenoid bone loss is there so that we can select the proper optimal treatment for these patients. So essential part of assessment is to understand that glenoid bone loss is a three-dimensional deformity which needs assessment in multiple planes. It needs assessment in multiple planes. In axial plane, we can do that using glenoid retroversion or modified Walsh classification. In coronal plane, we can use power classification or reverse shoulder arthroplasty angle, or we can do computer modeling, which kind of assesses the glenoid bone loss in both axial and coronal plane. In axial plane, the first thing is glenoid retroversion, which was originally described by Friedman in 1998. Plain X-rays tend to overestimate glenoid retroversion. That's why CT scans are better. In CT scan, there's a controversy if we should use two-dimensional CT scans or three-dimensional CT scans, because two-dimensional CT scans have potential errors in version measurement. This is because of the variation in the patient positioning, as the orientation of the scapula relative to CT scanner kind of influences which CT slice we are using for retroversion measurement. Budge et al. In this study, who compared the glenoid measurements done by 2D CT scans and 3D CT scans, they found that there was a difference of 5 to 10 degrees in 1/3 of the patients, which is a substantial amount of measurement error, which can lead to a lot of differences in clinical decision making. That's why it is advisable that we use 3D CT scans and take the proper slices to measure retroversion. Another way to assess glenoid bone loss in axial plane is using Walsh classification, which was described originally in 1999. Axial cuts on CT scans are used here. The factors which were considered in Walsh classification are the position of the humeral head in relation to the glenoid. Either it could be central or posterior subluxated, the presence of the glenoid erosion, and finally the degree of retroversion. This classification was modified in 2016 to have more number of types of glenoids. So type 1 is basically centered head. A1 is without erosion. A2 is central erosion. Type B is posteriorly subluxated. That means that the posterior subluxation is more than 55%. B1 is without version. B2 is biconcave with posterior erosion. B3 is a retroversion more than 15 degrees but with a central erosion. Type C is a dysplastic one in which the retroversion is more than 25 degrees. And type D is an anteverted glenoid with a subluxation of less than 40%. It is extremely critical for shoulder arthroplasty surgeons to know and understand this classification, because many of the research is using this classification to quantify glenoid bone loss, and even in our clinical practice, we use this routinely to compare our cases and to decide our management. If you talk about the incidence of Walsh types, if one type is more common than the other, the data is kind of, if you look at 3 studies, first is Walsh or the Sanchez study in 2019, or the Hopkins, we analyzed our patients between 2009 to 2017 to see that the incidence of Walsh types is very different in different studies. If you see the type A2 glenoid in Walsh study was 18%, or 12% in Sanchez. We found it to be over 50%. So one of the reasons for this variation in different studies could be because the patient demographics is different types of patients in different countries. So we cannot really say if this difference is because of the patient population study, or it is because of the inter-observer reliability with the modified Walsh classification. But Sanchez noticed in his ICL series that common mistakes made in the Walsh types while classifying them are between A2, B3, and type C. This is something surgeons should know of. A couple of studies looked at the reliability of modified Walsh classification. The original classification by Berry et al., which proposed modified Walsh classification, noted that there's a substantial agreement between the authors or between the readers. Sanchez et al. Found this to be just 0.5, which is moderate. So this is something which surgeons should be mindful about when they are reading the studies in which the glenoids were assessed based on glenoid bone loss. Another way to assess glenoid bone loss is in the coronal plane. This is very important because especially for reverse shoulder arthroplasty. If you look at the goals of reverse shoulder arthroplasty, is one of the main goals is to avoid superior inclination. This is important because there's increased stress at implant bone interface, which can lead to base plate failure. There's increased risk of scapular notching, and there's decreased shoulder range of motion. One of the ways proposed to assess glenoid bone loss in coronal plane is forward classification, which type E0 is no erosion, type E1 is concentric erosion, type E2 is limited to the upper half, type E3 in which the erosion extends until the lower half, type E4 in which only inferior erosion occurs. This is where moving on to the next concept of reverse shoulder arthroplasty angle, which was popularized by Below in 2018. To give you a background of this particular, the need of reverse shoulder arthroplasty angle assessment is, if you look at total shoulder arthroplasty prosthesis, it kind of occupies the whole of the glenoid surface. Hence, in order to know in order to plan, even if we measure the global inclination angle, which is the angle between the floor of the glenoid fossa and the face of the glenoid, it is sufficient. But when it comes to reverse shoulder arthroplasty angle, as we put the implant mainly in the lower half of the glenoid, we need to know what is the inclination angle at the inferior part, and that is where the concept of reverse shoulder arthroplasty comes in. So measuring reverse shoulder arthroplasty angle, a perpendicular is drawn to the scapular plane, that is the floor of the supraspinatus fossa, and then the angle between this line and the glenoid face is what reverse shoulder arthroplasty angle is. It really helps us to decide. What is the amount of correction we need if you are planning for eccentric reaming. It also helps us to determine, as it can be seen here, what is the amount of bone graft we need or the metal augment we need in order to get a neutral inclination angle. Another way to quantify glenoid bone loss is using computer modeling softwares, which are widely available now. This involves uploading a CT scan of the patient into these software applications. What it does is the first step is it converts these CT scans into a 3D format automatically. And this is the picture which it looks like, and we can play around with it, and we can visualize in the glenoid bone loss in different planes. Another thing which computer modeling softwares do is they give us the automated measurements of glenoid bone loss, like retroversion, inclination, and subluxation, like this. The surgeons do not have to do anything. As soon as we upload our particular CT scan in the software, they give us these values. As there are many applications which are available, the question arises where the automated measurements given by these softwares, are they reliable, or are they valid when compared to the measurements which are manually done by the surgeons? This was answered by this particular study which came a couple of months back. Erickson et al. Looked at 81 patients. They looked at the CT scans of the arthroplasty patients. They compared the manual measurements done by 5 experienced surgeons and automated measurements as given by 4 different softwares, computer planning softwares. They looked at 3 particular variables, the glenoid version, inclination, and subluxation. The authors did not find significant differences in the mean measurements by surgeons and the individual softwares. However, they did note that the softwares differed from surgeon measurements to some degree. And this is something we should be mindful about before relying on the automated measurements given by computer softwares. Computer modeling also helps us in deciding which type of implant we want to use. In the 3D format, we can virtually put our prosthesis, whether a reverse or a total. We can decide if we want to use an augmented component, so that how does the correction come up with particular augments. We are able to see that on the coronal and the axial planes. Another thing computer modeling helps us to do is to select the size and the position of the implant. It lets us decide different types of glenoid prosthesis, humerus prosthesis, what should be the length of this particular screw. It helps us to move the prosthesis on the bone up and down to decide what should be the particular position for each particular patient. And finally, one of the most important things which this softwares give us is what is the bone contact, what is the contact of the bone and the prosthesis, which is critical for the survivorship or initial fixation. To answer the question, does computer planning help with the selection of the implant type and size? Rice et al. In April 2020 looked at 200 patients and they compared the data from the computer planning software and what implant was finally inserted. They compared the implant type, the size of the implant, which was planned and which was finally inserted. And for reverse shoulder arthroplasty, they compared what the diameter of the base plate and other factors. They found that there was concordance of computer planning softwares and the final implant inserted by the surgeons, which was pretty high. In total shoulder arthroplasty, it was about 85%, and in reverse shoulder arthroplasty, it was 90%. Computer modeling softwares are widely used these days. They really help us to have a better understanding of our surgeries, of the deformity of the patients and the prosthesis we want to use. They're really helpful before the surgery. But there are some things which are still lacking and which are not talked about much, is that computer modeling softwares do not really assess or do not really give us an idea about the soft tissue balancing, which could be important for stability of the implant. Also, these softwares are not validated for planning for the surgery, even if they give, even if there are some studies which are there, which kind of compare the reliability of the automated measurements. But for surgical planning per se, we do not know if they are valid. Finally, different software applications use different CT acquisition protocols. So you may have to be, the surgeons have to be mindful that the patient is handed over the particular CT acquisition protocol before they have their CT scans, so that the CT scans which they bring to us are compatible with the particular software, planning software. With this knowledge, let's move to what are the various surgical options we have to deal with glenoid bone loss. So right now, this field is in evolution. There are many surgeons and researchers all over the world. They are bringing, they are trying different things, and the studies are coming up. With most of the implants, the studies are limited to short-term follow-ups. But in broad category, if you want to talk about it, then the surgical options really are total shoulder arthroplasty or reverse shoulder arthroplasty. So let's look at the various options we have with these two type of prostheses if we want to manage glenoid bone loss. If we focus on the options with total shoulder arthroplasty, we first need to know what are the 5 main goals of implant positioning. First is subchondral bone preservation, a glenoid retroversion of less than 10 degrees, a superior inclination of less than 10 degrees, implant seating of more than 80%, and posterior subluxation less than 80%. So total shoulder arthroplasty with glenoid bone loss, in order to achieve all those goals, it can be done in three particular manners. First is we can ream the glenoid flat with eccentric reaming, as it can be seen in this particular picture. The next one, other options we have is either using a bone graft to fill in the glenoid bone loss, or using augmented glenoids. Let's look at these 3 options one by one. For total shoulder arthroplasty with eccentric reaming, it is usually recommended for a retroversion less than 15 degrees, and we'll see why is that. Because the concerns, there's some concerns with when this particular method is used for retroversion more than 15 degrees, which is there's a loss of subchondral bone, that means suboptimal fixation of the glenoid base plate. There's increased risk of pec perforation. There's medialization of the center of rotation, and there's shortening of the cuff lever arm, which can affect the range of motion, or it can affect the function. Ho et al. In 2013 looked at 66 patients who were treated with total shoulder arthroplasty and eccentric reaming for glenoid bone loss. 62% of the patients in their series had a retroversion more than 15 degrees. One of the key factors of the methodology was that the surgical goal was complete implant seating with eccentric reaming. It was not to correct the amount of retroversion. At a mean follow-up of 5 years, they found no patients had revision, but osteolysis was present in over 30% of the patients. Osteolysis did not correlate with worse function. And they found that postoperative retroversion of more than or equal to 15 degrees was a risk factor for osteolysis. Another study by Orwitz et al., who looked at 59 patients with B2 type of glenoid, which is a biconcave glenoid. There were 4 surgeons who used a single type of total shoulder arthroplasty. They found at a mean, they included patients with mean preoperative retroversion of 18 degrees. Differently from Ho et al., this particular study had a surgical goal of correction of retroversion to less than 15 degrees. With this particular approach of reducing the retroversion to less than 15 degrees, they found there were no revisions. There was a radiolucency. However, the radiolucency was present in 22% of the patients, and there was functional improvement in all the patients at the final follow-up. Moving on to total shoulder arthroplasty using bone graft, which was proposed by Neer in 1988. Today we use autobone graft from humeral head or iliac crest. This technique has particular concerns of bone graft failure, suboptimal fixation, and it's technically difficult to do this. So let's see what the clinical studies say about this. Nicholson et al. Studied 28 patients in which they used total shoulder arthroplasty with humeral autograft. Patients had a retroversion ranging from 4 degrees to 28 degrees. At a mean follow-up of four years, they found that the functional improvement was there in all the patients. All the grafts were healed and there were no revisions, which are really encouraging results. Differently from that, Kilka et al. Looking at 23 patients with humeral autograft. Now there is a thing to be noted about this study is that 12 patients in this particular study had metal bag glenoids. So that may have resulted in, that may have been the reason, a confounding factor for failure in this particular cohort. At mean of 8 years of follow-up, there was a graft failure in 26% of the patients, which is a huge number, and it is very different from the previous study which we talked about. Looking at the systematic review of this particular prosthesis and technique type, Gates et al. Looked at 6 studies, 94 patients, and at a mean follow-up of 5.7 years in the included study, the graft failure rate was 17%. The radiolucency rate was 29%, and over 15% of the patients had, 14% patients had revision. With this, let's move on to total shoulder arthroplasty with augmented glenoid. The particular type of glenoids, total shoulder arthroplasty glenoids, which are available in the market with an augmented option are full wedge, hemi wedge, and step wedge. Favorito et al. In JSES, they published in JSES 2016, looking at 22 total shoulder arthroplasty patients using a step glenoid. They found that the central peg is uncemented in the prosthesis they used, and the peripheral pegs were cemented. All the patients had 100% component seating. In terms of clinical results of this study, at a mean follow-up of 3 years, the functional outcomes improved in the patients. However, there was a non-integration of central peg in 27% of the patients, and posterior instability was found in 9% of the patients. Looking at a study from Stevens et al. Using 21, who looked at 21 patients with stepped all polyglenoid, they had the prosthesis was similar to the one used in previous surgeries in terms of uncemented central peg and cemented peripheral pegs. At a mean follow-up of 35 months, they found that the functional function and range of motion improved in the patients, and the central peg ingrowth was seen in all the patients, but there was peripheral peg radiolucency was seen in 24% of the patients. There's another systematic review which looked at 4 studies which used total shoulder arthroplasty prosthesis with augmented glenoid. They found that the particular thing to note here are the studies which are available for this particular prosthesis and technique type have limited follow-up, and they have very small numbers. The sample size is really small, and the concerns of radiographic lucency are there with augmented glenoid using total shoulder arthroplasty. This is a newer study which came after the systematic review was published. This study was not included in that particular systematic review. Friedman et al. Looked at 68 patients with type B glenoid. The mean follow-up was of 15 months. The glenoid loosening was present in 3% of the patients. 90% of the patients had clinically significant improvement. So they saw encouraging results. So literally with total shoulder arthroplasty using augmented glenoid, the results in some studies are encouraging, but the science is developing, and we have to just wait and watch and see what the long-term results of with this particular prosthesis type is. With this, we move on to reverse shoulder arthroplasty. What options we have to address glenoid bone loss with RSA? So if you look at the surgical goals with RSA, there should be a base plate coverage of the glenoid bone of more than 50%. We should try to avoid superior inclination. Minimum 2 screws should have purchase in the glenoid bone. We should try to use a lateralized center of rotation prosthesis to ensure that we have impingement-free range of motion and reduced notching. And the retroversion should be corrected to either a neutral or 20%, 20 degrees. And this is a bit controversial though. So we have four options to address glenoid bone loss using reverse shoulder arthroplasty. First is either to rim the glenoid flat. Second is to use a bone graft popularized as bio-RSA, or use augmented base plate, or a customized glenoid. So looking at the first option with reverse shoulder arthroplasty, which is of reaming the glenoid flat, a specific concern with this particular technique is first is poor coverage of the base plate in already deficient glenoid, which may increase the chances of base plate failure. Second is medialized center of rotation, which can lead to reduction in the muscle strength, reduction in the range of motion, and issues with scapular notching. McFarlane et al., who is a pioneer of this particular technique, looked at their patients in 2016. The main goal of the surgery in this study was to have flat surface with maximum base plate and bone coverage. This was, and the particular key factor in the prosthesis which they used was a lateralized center of rotation glenosphere with a 135-degree neck shaft angle in order to have impingement-free range of motion and optimal function despite medialization. So McFarlane et al. Published in 2016, they looked at 42 patients which were treated with reverse shoulder arthroplasty with reaming the glenoid flat. They had mixed bunch of patients in terms of glenoid bone loss with, about half of the patients were type C, which is a severe type of glenoid bone loss. They looked at minimum 5-year follow-up and they found that the base plate, there was only one base plate failure, which amounts up to 2%, and the range of motion and the function improved in the patients at the final follow-up. There's another study which is under submission right now, which looked at which is kind of a concise follow-up study of the same particular cohort done by the same group. 31 out of 42 patients, original patients, were available at a minimum of 5-year follow-up. There were 2 base plate failures with which amounts up to 6% of failure rate. There was maintained and clinically significant improvement in range of motion and patient-reported outcomes. Scapular notching was present in about 19% of the patients, and we are still awaiting 10-year follow-up in this particular cohort. Moving on to reverse shoulder arthroplasty using bone graft, which is popularized as bio-RSA by below. The purpose of the bone graft here is not just to fill the defect, but it is also to cause glenoid lateralization. One of the key factors of the key recommendations of the proponents of this particular technique is that the patient-specific guide should be used if the retroversion is more than 25%. Below et al. Looked at 54 of these patients treated with this technique who had a mixture of posterior bone loss and superior bone loss. At a minimum of 2-year follow-up, they found that the bone graft and base plate failure rate was 6%, Notching was present in 25% of patients, and function and range of motion improved at the final follow-up. This systematic review came just last month, which looked at 13 articles and 437 patients which were treated with reverse shoulder arthroplasty and bone graft. At a minimum of 2-year follow-up, the bone graft failure rate is 8%, and the revision rate for primaries was 3%, and for revision was about 21%. These two studies looking at reverse shoulder arthroplasty with bone graft, they came after the systematic review was published, or these studies were not included in that particular systematic review. Ho et al. Published earlier this year, looking at 44 patients at a mean follow-up of just 8 months. They had a graft resorption rate of 25%, and base plate failed in 25% of the patients. So not so encouraging results. Collin et al. Published last year, where they looked at 16 patients, which was a part of a bigger study. But the 16 patients who had a bone graft at a 5-year follow-up, they found half of the patients had graft resorption. Again, kind of emphasizing that the results of the bone graft are controversial, and more studies are coming up. In future, we should be able to make a conclusive decision whether bio-RSA or bone graft really works with different authors. Looking at reverse shoulder arthroplasty with augments, there are a study by Zuckerman, which came out a couple of months back. They looked at 67 patients which were treated with 8-degree augmented base plates. There was a mixture of B2, B3, and C type of glenoid. At a minimum of 2-year follow-up, they did not find any base plate loosening. And patients had, over 90% patients had clinically significant improvement in range of motion and patient-reported outcome measures. Another study by Jones et al., they compared patients who were operated with augments or a bone graft using reverse shoulder arthroplasty. This was a multicentric study with a minimum of 2-year follow-up. None of the patients with augmented prosthesis had a failure, and 5% of patients with bone graft had failure. All the patients had improvement in function and range of motion. If the glenoid bone loss is extremely severe, then surgeons may have to consider the possibility of custom glenoids. Just a word that these prostheses are very expensive, and there are just 2 studies looking at, with a very limited number of patients, looking at the clinical results with this prosthesis. Rangarajan et al. Looked at 18 patients who had a minimum of just 1-year follow-up, did not find any base plate failure, and the results, the clinical, functional, and the range of motion improved in the patients. Similar results were found by DBR et al., who looked at 10 patients. So in summary of my talk, glenoid bone loss in shoulder arthroplasty. The assessment of glenoid bone loss is improved with 3D CT scan based computer planning softwares. Unique complications of surgical options drive this clinical decision making. For a retroversion of less than 15 degrees, total shoulder arthroplasty with eccentric reaming seems like an optimal option based on the literature review we did today. A retroversion of more than 15 degrees, we should consider a reverse shoulder arthroplasty. The use of bone graft with either of these techniques has concerns of graft incorporation, and the science is evolving in that particular aspect. Augmented glenoid implants have good results in short-term follow-up, but longer-term studies are needed. Thank you so much for joining me today. I hope this would help you to understand this controversial topic in a better way. The lockdown is due to COVID I believe it's the best opportunity for us to fill the bone loss in our family morphology, to reconnect with the loved ones. Thank you so much for joining again. Take care.